Hi, it's George Van Hare. Several of us have been asked to give some predictions for the future of our field of pediatric electrophysiology. And I will do so and just note that these are entirely speculative. My one disclosure is that I actually work for the FDA now. I'm a senior pediatric medical officer in the Office of Cardiovascular Devices and the Center for Devices and Radiological Health. And the agency would like me to make clear that all of the opinions that I'm going to express are personal and do not represent official FDA policy. So my first prediction, and this will unfortunately annoy some people, is I believe that adult cardiology will own adult congenital heart disease EP. In fact, I think adult cardiology is destined to own all of adult congenital heart disease, despite the fact that many of us continue to take care of some adults. And with that, I think our adult electrophysiology colleagues will also basically own EP in that group. And I think there's a number of reasons why this is inevitable, in my opinion. The first is that the number of congenital heart disease patients who are arriving in adulthood is increasing exponentially. And so that sheer volume is difficult for our small pediatric programs to cope with. Most arrhythmias in congenital heart disease patients, in fact, show up late. They actually show up in adulthood, and probably the best two examples of that are, first of all, ventricular tachycardia and sudden death in tetralogy of Fallot and related defects, where the incidence of that problem these days really doesn't start to rise until they're about 20 years out. And so this is a problem for our adult colleagues. And finally, atrial fibrillation. Many papers have cited the increasing incidence of atrial fibrillation late in congenital heart disease. And that's a big topic now in a lot of adult programs. I think the children's hospitals these days, in fact, have their hands full with hypoplastic left heart syndrome and other single ventricle patients with heart transplantations and things like that. In our hospital, if we suddenly decided to admit all of our adult congenital patients to the children's hospital, we wouldn't have any room for our pediatric patients. And finally, and most interestingly, I think that arrhythmias in adult congenital heart disease patients are way more interesting than most of atrial fibrillation, at least will turn out to be so for our adult colleagues. So I think it's only a matter of time before our adult colleagues figure out that this is a fascinating area that is worth their time and attention. Number two, I think that we have leadless pacemakers, and sooner or later we will figure out how to extract these. One of the things that has caused us a pause from placing a lot of leadless pacemakers in children is just the fact that we don't really have the tools for extracting them, and it's not really clear what happens when the device reaches the electric replacement indicator. But just remember that transvenous pacemakers have been with us for a very long time, in fact, since 1958. When Cy Furman started implanting these. But really, tools for lead extraction did not become available until 1988. So 30 years in the field before the tools for extraction actually became available. For leadless pacemakers, specialized tools do not yet exist for removing leadless pacemakers. There are tools, of course, to snare and remove devices in the short term, but in terms of taking out a device that's been there for 5 or 10 years with fibrosis and all the rest, not yet developed. And I think that the advent of dual chamber leadless pacemakers will, I think, drive the adoption of pediatric practice. But I think that management of these pacemakers at end of life will require the development of some of these specialized tools for extraction. But I think it's inevitable that they will be developed. And just to sort of note that I really think that extraction of these devices is likely to be much safer than extraction of leads, because there will be, in fact, minimal fibrosis and no issues with the SVC and perforation at that site. Next, staying on the topic of leadless pacemakers, sooner or later we're going to figure out how to use these in our single ventricle patients. I think we all know that single ventricle patients right now, if they need pacing, they really are relying on epicardial systems, and our performance of these epicardial systems is often disappointing, particularly in older patients. Using the sew-on buttons often doesn't work in older patients with fibrosis. And the active fixation or screw-in leads also have been disappointing. And I really think that most of the thrombogenicity for pacemaker lead is related to the lead, not the electrode. And I suspect that leadless pacemakers are likely going to turn out to be not particularly thrombogenic. And so I think a placement in the systemic ventricle is likely going to turn out to be feasible and safe, but that of course remains to be seen. Along that topic is this device that is currently in clinical trials. This is just from this company's website, so I'm not, revealing any information that's not publicly available. This is called the WISE CRT system, and basically what this is a tiny electrode that's in fact placed in the endocardium of the left ventricle for purposes of resynchronization. It's coupled with a standard transvenous lead in the right ventricle, and then a battery and transmitter that essentially uses ultrasound to cause pacing in the left ventricle through this tiny little receiver electrode. The point about this is that this is currently now basically a leadless pacemaker that's placed in a systemic ventricle and does not require long-term anticoagulation as a regular transvenous lead would. I think that conduction system pacing will become more widely adopted. I think we, just to sort of pause and define terms here, the term conduction system pacing these days now refers to two particular styles of pacing: His bundle pacing plus placement of a lead in the left bundle branch area. This is currently the accepted terminology for this approach. So His bundle pacing maintains a nice narrow QRS, maintains AV synchrony, and presumably can avoid pacemaker-induced cardiomyopathy. But there have been problems with His bundle pacing. Thresholds often are disappointing. R waves are poor. There are late exit block problems that have been observed, and in fact, the technique is actually fairly difficult to perform. But left bundle branch area pacing is now all the rage in the adult EP world for a lot of reasons. The first is that it's much, much easier to do, and electrical performance is much better. You get R waves and capture thresholds very similar to standard endocardial right ventricular pacing. And what it does is that it actually captures the left bundle branch in most cases, and that basically avoids desynchrony. And even more interestingly, in patients with pre-existing left bundle branch block, it often reverses or corrects that and gives you a nice narrow QRS complex, which is why it's become so popular. I suspect that because our patients are going to need a lifetime of pacing when they have heart block, particularly our congenital AV block patients. Increasingly we'll be thinking about this, but just the caveat is we need to figure out what happens when the lead fails. Similar to my statements earlier about the needing tools for extraction, the likelihood is that an extraction of a lead in this location is going to be much more complex than a standard lead extraction, and so we have to have some pause as far as that's concerned. And then finally, more pediatric labeling for devices. There's two things at the FDA that have been going on recently. The first is there is a guidance document on using adult data and extrapolating that to the pediatric situation in order to gain labeling for a device. And then the second thing is the concept of using real-world evidence or real-world data to support a decision by the agency that a device is safe and effective, and allowing it to be labeled for a particular population. And this is pretty exciting. I mean, most people believe that to get a device approved, it's going to take 1,000 patients enrolled in an 8-year trial. That's very expensive. But in fact, it's possible to extend labeling to the pediatric world using extrapolation of adult data and real-world evidence, depending on what the situation is and the quality of the data, and also basically the basic concepts of size and development. And here's an example of a recent success story. The Medtronic Cryocath system previously was not labeled for use in children. Despite that fact, of course, we were using it off-label. And there's a lot of advantages to getting labeling in pediatrics. But the way this actually happened was a combination of recognizing that the extensive adult data much of it could in fact be extrapolated to at least part of the pediatric population. And then second, we all have been busy writing papers about this, and it turns out there were nearly 1,000 children reported who'd undergone cryoablation. And so the combination of the reports in the medical literature and the ability to extrapolate adult data allowed the company to actually successfully add pediatric patients to their labeling who are over 2 years of age. Why do we care about this? Well, this means now that the sponsor, the manufacturer, can now sponsor educational symposia and address pediatric applications. They can share with us what they know about best practices for the use of their device in the pediatric population. We can talk to the manufacturer and learn what they actually know about their device. So I think that there are a lot of advantages to pediatric labeling, and we'll see more of this as we go forward in the future. So I will stop there and thank everybody for their attention to this topic.